Okay, this is video 19. We will continue with acute renal failure. So we will see what is acute renal failure, its definition. So it's a uremic syndrome, describe a set of manifestation that result from loss of renal function. So when we say uremic syndrome, so uremic means accumulation of the waste products. Okay, so it happens, okay, it is like a syndrome which happens because of loss of renal function. Terminology: uremia, urine in the blood. Then you see that is because the kidney is not able to excrete it outside. Oliguria, daily output of urine between 100 and 400 ml. When it is less than 400 ml, then anuria, absence of urine, or it can be less than 100 ml. There are two types of renal failure, which is the acute renal failure and chronic renal failure. So today we will be dealing about acute renal failure. So it refers to the abrupt loss of kidney function. Over a period of hours to a few days, the glomerular filtration rate decreases, serum creatinine and urea nitrogen or blood urea nitrogen or blood it is repeated, okay, level increases. So in the blood, if the BUN and urea creatinine increase, it shows that the nitrogenous waste is not being excreted from the body, and this can happen when the kidney stops functioning. We will see what are the various etiology and risk factors. So the numerous causes of ARF can be categorized into three major areas, that is pre-renal, intrarenal, post-renal causes. So we will see what are the pre-renal causes. So reduced renal blood flow lowers the GFR, which is the glomerular filtration rate, that is the amount of blood that is passed through the glomeruli every minute, and it is a test also which is done to see how well the kidney is functioning. Okay, so reduced renal blood flow lowers the GFR. So automatically when there is a less of blood, it reduces the blood flow to the glomeruli and lead to ARF, that is acute renal failure. So pre-renal causes of ARF are those that interfere with renal perfusion. Next, circulatory volume depletion. As may occur with diarrhea, vomiting, hemorrhage, excessive use of diuretics, burns, renal salt wasting, cause condition, or glycosuria. So any condition which actually leads to circulatory volume depletion, when the patient undergoes hypovolemia or less of fluid status, automatically it leads to acute renal failure. Next, volume shift, as form third space, sequestration of fluid, vasodilatation, or gram-negative sepsis. So when there is a volume shift that happens from intracellular to extracellular fluid, we will see what could be the various causes, which can be because of separation of the fluid. Sequestration is nothing but separation of the fluid. Vasodilatation, we know that, yes, so dilatation of the blood vessels, or gram-negative sepsis. When we say gram-negative sepsis, it is the condition where a person ends up having septic shock. Is a clinical syndrome characterized by circulatory insufficiency and inadequate tissue perfusion. So in this gram-negative sepsis, it leads to septic shock automatically, where the circulatory volume, okay, reduces and the tissue perfusion also reduces, and this becomes a cause for ARF. Next, decreased cardiac output, as during cardiac pump failure, pericardial tamponade, or acute pulmonary embolism. So again, the causes that leads to decreased cardiac output. So as we have seen, it can be because of cardiac pump failure, where the heart is not able to pump properly. And then when we have pericardial tamponade, so it is the compression of the heart caused by fluid collecting in the sac surrounding the heart. So surrounding the heart, you have this fluid collecting sac. When the fluid is getting collected, it actually leads to compression of the heart, and the heart is not able to pump. That is called as pericardial tamponade or acute pulmonary embolism. So in case of blood clot in the lungs, okay, where the blood flow is not there, automatically the blood cannot be purified, it cannot be sent to the heart, and thereby it reduces the cardiac output. Decreased peripheral vascular resistance, as from spinal anesthesia, septic shock, or anaphylaxis. So when we say decreased peripheral vascular resistance, it is the resistance in the circulatory system that is used to create blood vessel constriction. So what happens, because of the spinal anesthesia, sometimes it can lead to peripheral vascular resistance, where on the periphery there is vasoconstriction, Because of this, there is a decreased blood flow to the periphery, and this increases the systemic blood circulation. Vascular obstruction such as bilateral renal artery occlusion or dissecting aneurysm. So if there is both renal arteries occluded, obstructed, or in case of dissecting aneurysm. So dissecting aneurysm, imagine a artery like this, longitudinally it will be cut or dissected. In that case again the blood will not go through the blood vessel. Okay, so these are the various pre-renal causes which can lead to ARF. Now coming to intrarenal causes. So intrarenal causes of ARF include parenchymal changes. It is not ERF, it is ARF. Involve parenchymal changes caused by disease or nephrotoxic substance. So within the kidney, if there is any cause, then that can lead to ARF. So like acute tubular necrosis, damage to the tubule cells of the kidney. So inside the kidney, if the tubules are necrosed, there is no blood supply, damaged, then it is said about 75% of cases like this causes to ARF. Then renal trauma to the kidney such as surgery, crush injury or electric shock. Then severe muscle exertion, that is called as rhabdomyolysis. When the muscle is actually severely exertion or severely used, which can lead to damage to the muscle. Next, genetic conditions such as diabetes mellitus or malignant hyperthermia. So we know the diabetes mellitus need to nephropathy. Okay, and then malignant hyperthermia, this occurs in response to particular medication used during anesthesia. So when anesthesia is given as a side effect of a particular medicine, it leads to a disease called as malignant hyperthermia. So the patient will be characterized as a side effect, okay, it leads, and when we see patient will be having high fever, he will be having muscle rigidity and increased heart rate. Infectious disease, metabolic disorder like hypokalemia. So when the potassium level decreases, phosphate level increases in the blood, phosphatemia, or heat stroke. When there is dehydration, it affects the kidney. Then rejection of transplanted kidney. After transplanting the kidney, if the body is not able to accept it, that is called as rejection. Then renal artery lesion. So any lesions in the artery that hinder the blood supply. Other causes include glomerulonephritis, microvascular or large vascular lesion. So these are abnormalities in the blood vessel. Thrombosis, blood clot in the arteries. Vasculitis, it is the inflammation of the blood vessel that causes changes in the blood walls. Scleroderma, it is a chronic hardening and thickening of the skin and connective tissue. Atherosclerosis, plaque formation or fat deposition in the arteries. Tumor invasion, that is metastasis. Okay, cancer when it spreads, then necrosis, loss of blood supply. So these are the various causes of intrarenal causes for ARF. Next we will go to post-renal causes. So when we say post-renal causes of ARF, again it is ERF, please change in your notes, ARF, it arises from an obstruction in the urinary tract. So that is prostatic hypertrophy. When there is an enlargement of the prostate gland in the male. So they say this is also a precursor, of prostate cancer. So before cancer can develop, a person can end up having prostatic hypertrophy. Then invading tumors. When we say invading tumors, again it can be metastasis of tumors, spinal cord injury, pelvic trauma, calculi, renal calculi or urolithiasis. Then you have surgical accident, urethral stenosis, narrowing of the urethra and obstruction. So these are all the various causes. With the diagram, they have given it, they have written about pre-renal failure, okay, and then mainly that is involved with the circulation and the heart. Then we talk about intrarenal, which is associated mainly with the kidney, and then post-renal failure. Okay, so these causes can be because of the obstruction in the urinary tract. Okay, so with the diagram you can write down the causes. It is also very important. Next we will move on to pathophysiology. Talking about the pathogenesis, they say it is not clear, but they have given here 4 pictures indicating which can, actually the possibility which can lead to acute renal failure. So first one, pathogenesis of, as I told, it is not that clear. but it can be because of any etiological factor like pre-renal, intra-renal or post-renal. It can actually cause damage to the tubule, and because of this the tubules are not able to store or conserve the sodium. So whenever there is less of sodium, automatically it activates the renin. Okay, it is a hormone which is secreted by the kidney. So it activates this renin, which increases the aldosterone system angiotensin. Okay, or angiotensin, renin angiotensin. Okay, automatically it stimulates the aldosterone also. Okay, then this leads to the kidney try to redistribute the renal vascular supply. It can be because of any of the etiological factors. So now as a compensatory mechanism, the kidney is trying to distribute the blood, okay, to the tone of both afferent, through the afferent and efferent arterioles that is found in the glomeruli. And what happens? It leads to ischemia. When it fails to distribute the blood, it leads to ischemia, and which also leads to other factors like it increases the vasopressin, that is the antidiuretic hormone, which will try to reabsorb all the water. Okay, and then cellular swelling. This happens because when the reabsorption of water happens, automatically the circulatory volume increases, and then the blood is also shifted into the cells. So this cell is volume is increased because the water is increased in the cell. Inhibition of the prostaglandin synthesis. So this prostaglandin is not able to be synthesized because of these adverse effects that is happening. So usually the function of prostaglandin is it controls the blood pressure, and it provides relaxation and contraction of the muscle. So further stimulation. So what happens again? It stimulates the renin angiotensin system, which reduces the blood flow and it decreases the glomerular pressure, leading to decreased glomerular filtration rate and tubular flow, again leading to oliguria. So all the water in the body gets stagnated and less of the urine, it is excreted through the body. This is one of the, reason or pathophysiology of the ARF. Next we will see other therapy is that cellular and protein debris in the tubules. So whenever we find any cellular or protein debris, okay, the waste in the tubules, so it obstructs the lumen, so it raises the intratubular pressure, and then it increases the oncotic pressure, that is the protein. So we see that there can be accumulation of cellular and protein debris, and it will obstruct the lumen, so it can raise the intratubular pressure, it can increase oncotic pressure. This again opposes the filtration pressure and stops the glomerular filtration rate. So this is another theory. Next is biochemical theory that claims that when there is a decreased renal blood flow, it can be because of circulatory failure, hypovolemia, decreased blood flow. Okay, so what happens is decreased renal blood flow, it leads to decreased oxygen delivery to the proximal tubules. Then it reduces the cellular ATP. So when there is no oxygen, automatically ATP also decreases. Okay, so decreased blood flow because of any of the etiological factor related to circulatory system, it decreases the oxygen delivery to the proximal tubules. Again, it reduces the ATP, and we know ATP is required for so many functioning in the body. So it increases systolic and mitochondrial calcium concentration. So what happens? This ATP is decreased, so it increases the calcium in the mitochondria, and then it can lead to cell death and tubular necrosis. The tubules get necrosed, and then it leads to vasomotor nephropathy, which causes spasm of peritubular capillaries. So the capillaries of the tubules of the kidney are affected. It also leads to neuropathy, disease of the kidney, which can further damage the tubules. Okay, so again, if tubules are damaged, it leads to oliguria and ARF. Okay, and the last one is the leakage of filtered urine through damage tubule back into. So whenever these tubules are affected, what happens? The urine goes back to the peritubular capillaries, and chemical or morphological changes happen in the basement membrane of glomerular capillaries, which decreases the nephron filtration, leading to oliguria, further leading to acute renal failure. So these are the four expected pathophysiology that is given. Next we will go to clinical manifestation. So talking about the clinical manifestation, it is marked by several phases. Okay, so first phase you can see that it is once phase or initiating phase. So this period from precipitation to development of renal manifestation. This is a starting stage where the patient will end up having renal manifestations. Next you have aliguria, anuria phase. It is not anuris, it is anuria phase. So it is also called as non-oliguric phase. So here it lasts for 1 to 8 weeks. So where the patient will have less than 400 ml or sometimes less than 100 ml. Okay, so this is second phase. So first phase we have seen, this period actually starts where the patient will end up having renal manifestation, and secondly we have seen oliguric anuria phase where the patient will have this for 1 to 8 weeks. Next is diuretic phase. So in this phase a gradual or abrupt return to glomerular filtration leveling the both signal the diuretic phase of urine output 1000 to 2000 ml per day leads to dehydration. 25% of death may occur in this phase. So what happens from oliguria to anuria phase, patient will suddenly develop this diuretic phase where he will try to pass a lot of urine. So we have to be very careful because it leads 25% of death happens because of this diuretic phase. So if it is happening, then simultaneously water balance, fluid balance has to be maintained. Then recovery phase. Okay, so if the patient recovers from the diuretic phase, he will be in the recovery phase, which will happen within 3 to 12 months, almost a year it takes. Okay, then the client might turn into activity level similar to that the before of the illness. So he might have mild tubular abnormality, glycosuria, presence of glucose in the urine, then decreased concentration ability. Okay, risk for fluid and electrolyte imbalance, especially during times of stress. So in general manifestation we will see that patient will have fluid and electrolyte imbalance. So it can be because of fluid overload also can happen, or dehydration can happen. Then hyponatremia will be there, hyperkalemia will be there, hypermagnesemia, acidosis, increased susceptibility to secondary infection. So because of this the patient can have other associated diseases. Then platelet dysfunction will be there in the patient. Then gastrointestinal complications like anorexia, constipation or diarrhea, nausea and vomiting, stomatitis. Next you have anemia, and then increased incidence of infection of the pericardium, that is pericarditis. Uremic encephalopathy characterized by, so uremic kidney disease where the blood urea nitrogen, the nitrogenous waste is not being able to excrete it. So in that case the patient will develop uremia, and he will have certain symptoms like apathy, that is lack of interest, lack of enthusiasm in the patient, episodic abundantation. So at certain times, you will see that the patient will be having altered level of consciousness. He will not be that alert. Then tremors, shakings will be there. Then coma, defective recent memory. He will not be able to remember anything very recently. Then dysarthria, it is difficult, unclear articulation of speech. They will not be able to talk continuously. Okay, there will be difficulty in articulation of the speech, and impaired wound healing will be there in the patient. So these are the various clinical manifestations that we have seen. There are phases, and then in general manifestations we have seen again 9 points. Okay, management, talking about it, nursing, intervention. So here we have to stay focused on the primary disorder and monitor for complication, assist in emergency treatment of fluid and electrolyte imbalance, assess progress and response to treatment, provide physical and emotional support, keep family informed about condition and provide support. So when we say we have to assess the condition of the patient, make sure that the patient does not end up complication. Mainly we have to monitor the fluid and electrolyte balance, give psychological support to the patient as well as the family members. Next, monitoring fluid and electrolyte levels. So here we have to screen the parenteral fluids, all oral intake medication for hidden source of potassium. Okay, so we have to make sure that we don't give anything extra, food, right, which has got extra potassium. Already hyperkalemia will be there in the patient. So fluid intake has to be assessed, then parenteral fluid, the amount, intake and output chart has to be maintained. Monitor cardiac function and musculoskeletal status. For signs of hyperkalemia will be there. So see that the heart is functioning properly, there are no musculoskeletal abnormalities. Monitor serum levels, because if there is hyperkalemia, we will see that there will be a tall peaked T wave. So we have to observe the ECG to see if the patient is having marked hyperkalemia. Then pay careful attention to parenteral urine intake, gastric output, wound drainage, perspiration, changes in body weight, edema, distension of jugular veins, changes in heart and breath sounds, and increasing difficulty in breathing. All this we have to check. It also shows that the lungs it can lead to pulmonary edema, so we have to be very careful. Auscultate lungs and moist crackles. Assess for generalized edema by examining presacral and peritibial areas regularly. So presacral, peritibial, we have to examine for edema and skin excoriation, which can lead to again skin care has to be given. Report indicators of deteriorating fluid. In case any kind of fluid loss is there reported, signs of hyperkalemia, you have to report it. Prepare the patient for dialysis as indicated to correct fluid and electrolyte imbalances. So management medical, when we say patient will be undergoing hemodialysis or peritoneal dialysis. So it is important that we have to inform to the patient. Next we have reducing metabolic rate. We have to reduce exertion and metabolic rate during most acute stage with bed rest. So make sure that you provide bed rest to the patient. Then prevent or treat fever and infection promptly. So if the patient has fever, immediately we have to treat the patient of fever, and then promote pulmonary function, ask patient to turn, cough, take deep breath frequently, encourage and assist the patient to move and turn. So to prevent any kind of pulmonary edema in the future. Avoiding infection, so we have to practice asepsis. Make sure that we use only aseptic technique for the patient while putting catheters or invasive lines to the patient. Avoid using an indwelling catheter if possible to prevent infection. And then the patient can also ambulate. So that's the reason it has to be done. Then providing skin care, perform meticulous skin care, massage body prominences, take patient frequently. So we have to massage the bony prominences, turn patient frequently, encourage bathing, tepid water for comfort, and prevent skin breakdown. For that, if the patient is able to ambulate, we have to make them ambulate, turn the patient, give massages and inform the patient to follow active exercises, and then bony prominences should be taken care. Next, providing support during dialysis. So making sure that we provide support for the patient during dialysis. So dialysis is the main management when it comes for this acute renal failure. So we have to assist, explain to the patient, family. We should not overlook psychological needs and concerns. So provide psychological support. Patient will be too depressed and it is also expensive for the patient. And then we have to explain the rationale of treatment to patient, why we are doing, repeat explanation and clarify any doubts. Then we have to encourage the family to touch and talk to patient during dialysis. So if they are allowed, they can sit, they can just touch and talk, or the nurses can make sure that you provide psychological support. Continually assess patient for complications like pericarditis, bone disease, anemia and their precipitating causes. Even when the patient is on dialysis, we have to make sure that you assess the blood pressure, urine output of the patient. So this is all about acute renal failure. So in the next class, we will continue with other conditions. So we have seen what is the definition and then terminology, what is acute renal failure, etiological factors with the diagram, prerenal, intrarenal, postrenal, pathophysiology, 4 types, and clinical manifestation phases and other manifestation, then management. So mainly it is hemodialysis, and then what are the nursing intervention under that, monitoring fluid and electrolyte balance, reducing metabolic rate, promoting pulmonary function, avoiding infection, providing skin care, providing support during dialysis.